Welcome to the image analysis of the toe. We will be reviewing the common projections, the apiaxial, oblique, and lateral projection of the toes in the image analysis guidelines. We will review some common positioning errors and how to take corrective action. Image analysis guidelines for the apiaxial projection of the toe or toes states that the midshaft concavity and the soft tissue width are equal on both sides of the phalange. The IP and the MTP joints should be demonstrated as open. The phalanges are demonstrated without foreshortening. No soft tissue or bony overlap from the adjacent digits is present. If imaging just a single toe, the IP joint for that toe and the PIP joint for that toe to the fifth toes is at the center of the exposure field. If imaging in the apiaxial projection all the toes at once, then the third metatarsal phalangeal joint should be demonstrated at the center of the exposure field. The phalanges and half of the metatarsals are all to be included within the exposure field. Here are those image analysis guidelines for your review. Proper positioning in the apiaxial projection of the toe is essential for accurate imaging. When there's lateral toe rotation, the foot and toe are rotated outward. This results in greater soft tissue width and midshaft concavity on the medial side, which is positioned away from the image receptor. Conversely, when there is medial toe rotation, the foot and toe are rotated inward. In this case, the soft tissue width and midshaft concavity appear greater on the lateral side, which is farther from the image receptor. To ensure open joint spaces and to prevent foreshortening of the phalanges, the central ray must be properly angled to that 10 to 15 degrees. That alignment brings the central ray closer in alignment with the joint spaces, allowing for them to be demonstrated as open and more perpendicular to the distal phalanges, which will reduce that phalangeal foreshortening. It's critical that we employ proper positioning and central ray techniques so that we are ensuring we're producing quality imaging. We have come to our first practice analysis. Please review the imaging and answer the following question. Let's review this image analysis practice together. In this apiaxial toe projection, improper positioning has resulted in an increase of soft tissue width and midshaft concavity on the medial surface, indicating that the lateral toe it's in lateral toe rotation. In order to correct this, we need to immediately rotate the foot and toe until they are flat against the imaging receptor. I'll give you time to analyze this practice analysis and answer the following question. Let's review this image analysis together. In this apiaxial toe projection, mispositioning has led to an increased soft tissue width and midshaft concavity on the lateral surface. This indicates that the medial there's medial rotation of the foot and toe here. In order to correct this, we need to laterally rotate the foot until the plantar surface is flat against the imaging receptor. Go ahead and review this last AP axial toe practice analysis and answer the following question. In this AP axial toe projection image analysis, several positioning errors are present. First, the IP joint spaces are demonstrated as closed, and the distal phalanx appears foreshortened. This indicates there's some improper central ray alignment. The toe is flexed as well. So we really do need to correct this. Also, the soft tissue superimposition is present between the first and second toes. To correct these errors, we need to try and extend that toe until it's flat against the IR. If the patient is unable to extend that toe, we could increase the central ray angulation or elevate the toe and forefoot on a radiolucent sponge to align the joint spaces and the phalanx more properly. In addition, we also need to separate those toes to avoid that soft tissue superimposition. These adjustments, ensuring open joint spaces, they ensure reducing that foreshortening and improve anatomic positioning, improves your imaging clarity. Let's move on to the AP oblique projection. Image analysis guidelines for the AP oblique projection of the toe or toes state that twice as much soft tissue width and more phalangeal concavity are present on the side of the digit rotated away from the IR. The IP and MTP joint spaces should be demonstrated as open. The phalanges are demonstrated without foreshortening. No soft tissue or bony overlap from the adjacent digits is present. If imaging a single toe, the first toe interphalangeal joint should be at the center of the exposure field. For the second through fifth toes, the PIP joint should be demonstrated at the center of the exposure field. If imaging all the toes collectively together, the third MTP joint should be demonstrated at the center of the exposure field. The phalanges and half of the metatarsals are all to be included within the exposure field. Here are those image analysis guidelines for your review. Proper toe obliquity is essential for an accurate AP oblique toe projection. When there is insufficient toe obliquity, the midshaft concavity of the proximal phalanx and soft tissue width will appear nearly equal on both sides of the digit. It'll basically look like an AP projection. This indicates that the toe was not adequately rotated. Conversely, when there is excessive toe obliquity, the soft tissue width is more than twice as thick on one side, and the posterior midshaft of the proximal phalanx will show greater concavity than the anterior aspect. This should indicate to you that the toe was over-rotated beyond that 45 degrees. To ensure proper imaging, you want to adjust that toe rotation to between 30 to 45 degrees with the IR. Go ahead and review this first practice analysis for the oblique projection and answer the following question. Let's review this practice analysis together. In this AP oblique toe projection, you can see that the soft tissue width and midshaft concavity is demonstrated nearly equal on both sides. This indicates that the toe is rotated less than that required 30 to 45 degrees. To correct this, we want to increase that toe and foot obliquity until the affected toe is positioned at a 45-degree angle with the image receptor. Proper alignment of and positioning of the foot will ensure and improve your joint space visibility and anatomic representation. Let's move on to the lateral toe projection. Image analysis guidelines for the lateral toe projection state that the condyles of the proximal phalanx should be superimposed. There's no soft tissue or bony overlap from the adjacent toes. The IP joint for the first toe should be at the center of the exposure field. When demonstrating any toes from the second to fifth toes, the PIP joint should be demonstrated at the center of the exposure field. The phalanges and metatarsal phalangeal joint spaces are all to be included within the exposure field. Here is an example of proper patient positioning for the lateral projection. For the first digit, it should be closest to the IR, and for the fifth digit, we should rotate the foot in the opposite direction to get those toes closer to the IR. Here are those image analysis guidelines for your review. In a lateral toe projection, proper rotation is key to achieving that accurate imaging. When there's insufficient toe rotation, the condyles of the proximal phalanx are not superimposed, and the metatarsal heads will appear posterior to the first toe. This indicates that the toe and foot are not rotated enough to achieve that true lateral projection. When there's excessive toe rotation, the condyles of the proximal phalanx are not superimposed again, and the metatarsal heads will appear either superimposed or anterior to the first toe. This should indicate to you that the toe and foot are rotated too much for the proper lateral projection. Go ahead and review this first practice analysis of the lateral toe and answer the following question. Let's review this practice analysis together. In this lateral toe projection, there is some obvious superimposition here. Taking a look, the soft tissue and bony overlap should indicate to you that we're not in a true lateral projection, and that we're not demonstrating our anatomy very well. The adjacent unaffected digits are not separated from the affected toe, leading to excessive superimposition. In order for us to correct this, we need to draw the unaffected toes away from the affected toe to eliminate overlap and ensure clear visualization of the targeted toe. We should use tape or any type of immobilization device if necessary to maintain that separation during exposure. Go ahead and review this next practice analysis and answer the following question. In this lateral toe projection practice analysis, there is a couple misalignments here. As you can see, the condyles of the proximal phalanx are not superimposed. The metatarsal heads are demonstrated anterior to the first toe. This indicates that the foot has been excessively rotated. In order to correct this imaging error, we need to decrease that foot rotation until the toe is positioned in a true lateral projection, ensuring that the condyles of the proximal phalanx are superimposed and the metatarsal heads are correctly aligned. Go ahead and review this last practice analysis and answer the following question. In this lateral toe projection practice analysis, if you take a look at the condyles of the proximal phalanx, they are not superimposed again. So we're talking about some insufficient or over rotation here. Next, you want to look at the position of the metatarsal heads. They're demonstrated posterior to that first toe. That should indicate to you that the foot is under rotated. In order to correct this, we need to increase that foot rotation to ensure proper positioning of the proximal phalanx condyles and that they're superimposed. This concludes our image analysis of the toes. If you have any questions, feel free to reach out.